Your foot doctor might not be a specialist at all, and you have no way of knowing just by sitting in their office. There are 4 specific warning signs that reveal whether a person treating you actually has the training your condition requires, and most patients miss every single one. Every week, patients walk into my practice after years of being treated by the wrong type of provider. They come in after 3 surgeries that didn't work. They've been told there's nothing more to do. After another doctor recommended amputation, and they find out a proper workup was never done in the first place. This isn't rare. This is a pattern. In this video, I'm going to walk you through 4 warning signs your doctor may not have the specialized training your condition actually requires. By the end of it, you'll have a clear, practical way to evaluate your current care and know exactly what to do if you see these signs. When a doctor gives you a recommendation, most patients assume it's the best option for their specific situation. They assume the doctor weighed the alternatives and landed on the right one. This feels like what expertise looks like. Confidence sounds like mastery. When a doctor says, "Here's what we're going to do," the certainty feels reassuring. Most patients don't know enough about foot and ankle medicine to question it, so they don't. A true foot and ankle specialist knows 5 to 10 approaches for most conditions: conservative approaches, surgical approaches, minimal invasive techniques, combination protocols, the full range. When a doctor presents one option, or 2 at the most, that's almost never because your condition only has one solution. It's because the doctor has access to a limited set of tools. And when the only tool you have is a hammer, every problem starts to look like a nail. If your doctor told you surgery was the only way forward without walking you through several alternatives, that's not a comprehensive recommendation. That's the limit of what they know how to offer. A patient-specific treatment plan comes from a full toolbox. It accounts for your age, your activity level, your comorbidities, your goals, the severity of the condition, and what you want your life to look like after treatment. That plan looks very different for a 42-year-old who runs marathons than it does for a 71-year-old managing diabetes. One option fits neither of them. When you see a true specialist, the conversation differs. You hear about the full range of options. You hear why some are better suited for your situation than others. You're part of the decision. The recommendation is built around you, not around the procedure the doctor happens to perform. Patients come in after receiving amputation recommendations from multiple providers, in some cases 3 separate physicians, and find out basic vascular test was never performed. The recommendation was made before the workup was complete. That's what a limited toolbox looks like, and it's most consequential. When you go back to your doctor or when you see a new one, ask directly, what are all the options for my condition? If this answer is thin, well, that's information. The second warning sign is about what happens before the recommendation was ever made. Most patients assume a surgical recommendation means the doctor has done everything necessary to confirm it's the right call. The recommendation itself feels like a conclusion of a thorough process. Patients aren't trained to ask what tests were run before a recommendation was made. They see an X-ray on the screen, hear a clinical explanation, and assume that workup was complete. The system makes it easy to trust the sequence without questioning it. Over half the amputations recommended in this country were made before basic vascular testing are done. Vascular testing, the most fundamental assessment and understanding of whether a limb has adequate blood flow. A doctor can look at a foot, take an X-ray, and recommend amputation without ever checking whether the tissue could heal if circulation was restored. That's not a complete workup. That's a premature conclusion. If your doctor recommended surgery or amputation and you've never had imaging beyond a basic X-ray, you've never had a nerve test, you've never had a vascular test, the recommendation you receive may be based on incomplete information. Not wrong necessarily, incomplete. And incomplete information leads to outcomes that could have gone differently. Diagnostic podiatry means getting the right diagnosis the first time. Full history and physical. Advanced imaging when the situation calls for it. Nerve testing when numbness or neuropathy is part of the picture. Vascular testing when wound healing or circulation is of concern. Using the technology and advanced modalities available today, not defaulting to visual assessment or a recommendation. A specialist builds the case before making the call. The diagnostic procedure isn't a formality, it's the foundation. When the workup is thorough, the treatment plan is accurate. When the workup is skipped or abbreviated, the plan is built around a guess. A patient came in after 3 amputation recommendations across 7 providers. A proper vascular workup had never been completed. Once it was, limb salvage path became available. The leg was saved. The recommendation to amputate wasn't wrong because the doctors were malicious. It was wrong because the foundation diagnostic work was never done. Before any surgical recommendation, ask your doctor, what tests did we run to confirm this is the right approach? What imaging was done? What vascular function was assessed? The answers will tell you whether you have a complete picture. The third warning sign is about what happens between your appointments, and it reveals a lot about how the practice is actually structured. If this is useful to you, subscribe before keep watching. This channel covers foot and ankle conditions, amputation prevention, and things most patients are never told, and there's more coming you'll want to see. Think about the last time you had a question for your foot doctor between appointments. What did you do? Call the office? Get a nurse who said they'd pass it along? Use a patient portal and wait days? Or did you just wait until your next visit and hope the issue hadn't progressed? Most medical practice are structured so that reaching the actual physician is difficult by design. There are layers between you and the doctor. Staff portals, triage calls, callback windows. For routine follow-up, that structure is manageable. For foot and ankle conditions, where things can change quickly and the difference between being caught early and being caught late can be the difference between a healed wound and an infected one, then that structure is a problem. Ask yourself, does my doctor know what's happening with me between visits? If something changes, if the wound looks different, if the pain shifts, do I have a way to communicate that to my doctor directly and promptly? And does my doctor actually respond? Access to physicians isn't a luxury, it's part of the care model. A specialist who genuinely invests in your outcome doesn't disappear between appointments. They stay available because they understand that the foot and ankle condition doesn't wait for your next scheduled visit. Every patient should have a way to reach their doctor when something changes. Every question in the appointment room should be answered before the patient leaves. That's what appropriate care looks like. The fourth warning sign is the one that almost every patient misses. It's buried in the description of something that sounds completely routine. If your doctor describes a surgical recovery that would take months, a cast, a crutch, a long period off your feet, and never mention that there are other approaches exist, pay attention to that. Many of the surgical techniques used in standard orthopedic and general podiatry practice are between 20 and 30 years old. They work, they're familiar, they carry the recovery burden that old techniques carry. Minimal invasive foot surgery uses a small incisional approach, and in many cases, no sutures required. Early weight bearing and active recovery are standard for patients who are candidates. The goal is to get the patient moving as quickly as possible because controlled motion supports healing. This isn't experimental. It's a modern standard for appropriately trained specialists. Stop assuming that a difficult recovery is an unavoidable part of foot and ankle surgery. For many conditions, not all, a patient who's had a bunion correction with a minimal invasive technique was walking in a surgical shoe the same day. That outcome isn't possible with traditional open procedures. If a doctor never mentioned it, it may not have been in their surgical repertoire. Ask specifically, are there minimal invasive options for my condition? What would early weight bearing look like for me? What's the recovery difference between a traditional approach and a less invasive one? A specialist who offers these techniques will be able to answer those questions clearly. A specialist who doesn't may redirect you or give you a vague response. The last section is the most practical way of this video, a simple way to take what you just learned and apply it tonight. You don't need a medical degree to assess whether you're seeing the right specialist. You need 4 questions. Ask them of yourself about my current care, and the answers will tell you clearly where you stand. 1. When my doctor made a recommendation, did they walk me through the multiple options, or did they present one path? 2. Before any surgical recommendation was made, was a complete diagnostic workup done, including imaging, nerve test, vascular assessment? 3. Did I have a way to reach my doctor directly between appointments? And do they actually respond? 4. If surgery was discussed, did my doctor mention minimal invasive techniques and what active recovery could look like for me? Think of these 4 questions as a checklist you run through before trusting any complex system with something important. You wouldn't hand the keys to your house to someone without knowledge of whether they had the right training to do the job. You'd ask, you'd check. The same standard applies here, and it applies to something far more important than your house. Patients lose limbs that could be saved. Patients undergo recoveries that were longer than necessary. Patients go years without an accurate diagnosis because the first specialist they saw didn't have the tools or the training to find it. These outcomes aren't inevitable. They're a result of a mismatch between the condition and the provider, and that mismatch is detected before it becomes irreversible. Tonight, go back through what happened in your care so far. Think about the last appointment. Think about the recommendations you received. Run the 4 questions. If you're checking boxes with confidence, that's a good sign. If you're pausing on 1 or 2 or all 4 of them, that pause is worth listening to. The 4 signs in this video aren't rare. They show up consistently in practices across this country, in care that looks normal from the outside. The doctor has a degree, the office looks professional, the recommendations sound certain, but credentials and confidence aren't the same thing as specialized training. And specialized training is what determines the outcome when the stakes are high. If you found yourself pausing on any of these 4 questions, there's a video on this channel that'll give you a full picture of what the training actually is. It's called Podiatrists versus Orthopedic Surgeons for Foot and Ankle. One trained for this, one didn't. It covers exactly why the training gap exists and what it means for the outcome, and how to make sure you're seeing the right type of specialist for what you have. Watch this next.